Okay, welcome everybody to our third learning session. I can't believe how fast this past year has gone by, basically. And we only have one learning session left after this. So as we begin, I ask if you're able to put your cameras on, and in the chat, let's have you put your name, your organization, and where you're calling in from. Let me get the presentation up. All right, so this is a quick look at our agenda. We have some really amazing speakers that I am really excited to introduce you to soon. There is one new exercise we're going to try today. Think of it kind of as our own little PDSA cycles, if you will, but we're going to test out doing some breakout rooms. About halfway through the session, we have 4 rooms that we're going to have you go into. 3 of them are going to be led by some of our speakers here today. It'll be an opportunity to ask some more questions and get some more like individual feedback. And so hopefully being in a smaller group, it won't be as intimidating to come off of mute and ask a question as it is when you're in a large group. So we're really excited about that. And so as these speakers are sharing, get your questions ready, think of some stuff you can be asking, and don't be shy. So hopefully the smaller groups, you'll be a little bit easier to come off of mute and chat. Next up, we have some very exciting news. We have a new member of our NSDPQC. Our very own Alicia Belai had her sweet baby Zion last month. Although the delivery was a bit rough, both mom and baby are home and thriving. And she says he is growing way too fast for her. But I mean, look at those just sweet cheeks and those dimples. He is such a cutie. And really fun fact, that basket he is pictured in is his grandmother's basket from Ethiopia. So we want to welcome baby Zion, and we hope Alicia is continuing to heal and enjoying her leave. Next up, we are going to watch a video from the CDC Hear Her campaign. Sorry, let me get that video up and sharing, and then we will watch that. I just need to admit a couple people. And I've got so many screens up on here. Give me 1 second.
I had heard of preeclampsia before, but I had never experienced it due to the fact that my first pregnancy was so normal. I have 4 kids. They are 8, 4, 3, and 2. First pregnancy was pretty normal. Everything was smooth sailing, and it was just typical. The second pregnancy, I had a few complications and developed preeclampsia. The headaches and wouldn't go away, and then my blood pressure was very high. Since my first pregnancy was so normal, the second pregnancy, the signs and the symptoms, I was able to recognize those as not being normal. I was able to compare the 2 pregnancies. When the symptoms started coming, I was a wreck. I was very nervous. I was very scared. I felt a lot of self-pressure, especially like, is it something that I ate causing this, or is it something? And then when I would voice my concerns, sometimes it would be, oh, you're pregnant, your feet are supposed to swell, or oh, you're fine, you're pregnant, like it's fine. But I didn't feel fine. All these symptoms are happening at the same time. The headache and the blurred vision, that's another thing related to the headache, was the fact that I had the blurred vision and the almost like sunspots. So I knew that these were related. So we went to the hospital and they ended up inducing me, and I ended up having my son, who was healthy and happy. But even after having my son, my legs my ankles and feet were so swollen that they were doing ultrasounds. They were worried about blood clots and very worried because it was just so severe. My advice to women, you know your body better than anyone else in the world. You're your number one advocate. Be proactive about stuff. If you feel something is a little off, go check, go make sure, talk to somebody, express how you feel. It could be nothing, and if it is, great. But if it's something serious, it's better to catch it in the beginning than just to think that it's normal pregnancy and everything's gonna be okay, and it was something that could have been prevented. Hear her.
Okay, I just love those videos and those personal stories from those patients. So next up, let me get the slides back on. Okay, so now, excuse me, we are going to hear from Tiffany Knopf again. She is the Health Systems and Hypertension Coordinator for the North Dakota Department of Health. In her role, she works with health systems, clinics, and pharmacy partners to improve the prevention, diagnosis, and management of patients with hypertension. She's been vital in all of our blood pressure training protocols. And I know a lot of you probably had emails from her about these trainings and everything. So Tiffany, if you want to come off mute, and she's just going to share some of the data from the last couple sessions of training.
Yeah, sounds great. Go ahead. You can go to the next slide, Morgan. Thank you. Good morning, everybody. Happy Thursday. I don't know how the weather is in South Dakota, but I have to tell you, in North Dakota, I am ready to open my windows today. It's supposed to be a high of 65 or more. So heat has been off for a week. Thank goodness. We are all ready for some beautiful sunshine. So I just wanted to cover the blood pressure protocol training. I know I've received a lot of emails from you recently about some future trainings, and we'll talk about that here in a second. But for those of you that are new to this training or to the NSDPQC and listening in, these are the objectives for our blood pressure protocol training. Basically, it's ensuring that blood pressures are being taken accurately. We know that it's so vital to get an accurate blood pressure, otherwise diagnosis and management all goes down the tubes if you don't have an accurate blood pressure. So these are the objectives of our training. You can go ahead to the next slide, Morgan. I know a lot of this is review, so I'll fly through it pretty quickly. So a couple of the competencies, I do like to review this because this is nursing 101, and that is exactly what we say in our training. None of this is new, but I have to tell you that these are the most common errors, and you'll see here shortly what the staff from the NSDPQC partnerships have said that they're willing to do or need to do to make sure that they're taking blood pressures accurately. Couple of things that are, like I said, the most common: having a patient have a bare arm, making sure that we are not putting cuff over clothing, especially again in North Dakota, South Dakota, we have to bundle up, right? 9 months out of the year, we're wearing multiple layers. And so, making sure that we're putting a cuff on the bare arm. And then making sure that the staff is not talking to the patient and the patient is not talking to the staff while they're taking the blood pressure or before. So just, letting them sit down, take a deep breath, and then take the blood pressure in some quiet. And then making sure that we are retaking the blood pressure. If a patient is elevated, you can wait a couple of minutes and then retake that blood pressure. Cuff can stay on the patient's arm as long as all of the pressure is off the patient's arm. And the bladder is empty, we can go ahead and leave that on a patient's arm and then retake the blood pressure in a couple of minutes. You can go ahead to the next slide, Morgan. So just wanted to pull up some content to compare the two trainings. So back in May, we offered a training in May and December of 2021. We did train across all 11 locations, and we had 320 total attendees. 82% of those attendees indicated that they are going to make a change as to how they take a blood pressure. And they listed specifically in high numbers things like cuff size, making sure that they're getting an accurate cuff size for patients, patient positioning, again, feet flat on the floor, legs uncrossed, back supported. not talking to the patient during blood pressure, cuff over clothing, and ensuring an empty bladder. Now, this is something we do talk about often in the NSDPQC blood pressure protocol trainings. Not only does the bladder of the cuff need to be empty before you're taking a blood pressure, but also the patient's bladder. I can tell you I've had 2 babies, and every time I would go into the OB's office, I would have a full bladder, because if I was getting an ultrasound, they'd tell you to drink a bunch of water, and I never wanted to not drink enough water. So I always drank way too much, and I would always have to go to the bathroom. And so, if a patient's blood pressure is elevated because they just ran from ultrasound, or they just ran in and they didn't know if they were going to have to give a urine sample, if they're a prepared patient, they probably have a full bladder. So getting them in to be able to use the restroom, especially if their blood pressure is elevated, get them in to be able to use the restroom and then retake that blood pressure. So for February of 2022, we offered 4 trainings. We had 93 attendees across 11 locations. 75% of the attendees said they're going to make a change. And again, things that we saw were cuff size, patient positioning, not talking, and then cuff over clothing. Go ahead to the next slide, Morgan. So we currently do not have any blood pressure protocol training scheduled. So this training originally pre-COVID was offered in person and in person only. After COVID started, we started to offer this training virtually. And now we are working on transitioning this training over to a virtual continuous CE option. So what that means is in the next couple of weeks is my hope. We've got a lot going on. And unfortunately, this has just fell on the back burner of our IT team. But the blood pressure protocol training will be converted into a platform called ND Train. And so I'll be able to send out usernames and logins to your sites. You'll be able to log in. Your staff will be able to watch the blood pressure protocol training on demand whenever they are interested. They will have to take a pre-test, post-test, and complete an evaluation, and then they will get their continuing education certificate sent directly to them. So again, I don't know exactly the date that this will be live, but Morgan, I will let you know the day it goes live so you can make sure to send this out to all the sites. So just keep an eye out. I know, like I said, several of you have reached out to me, and I'll make sure that I get you all notified as soon as this goes live. You can go ahead to the next slide, Morgan. So that is really all I had. I am here to answer any questions. I'm here to help. If your sites are working on things related to accuracy and blood pressure management and you want to talk through some things, I know I've helped a couple of sites think through some workflow challenges that they have related to blood pressure accuracy. So I'm here to help. This is my contact information, and you're welcome to reach out to me anytime. And otherwise, I'll take some questions.
Hey, this is Katie in Sioux Falls. Sorry, I couldn't get off mute there.
That's okay.
From your percentages that went down from the 80 plus down to the 75 for those that made a change, was there repeat people who went?
We did have some repeat. Yep, we did have some repeat. And honestly, it's a really, how we had to design the evaluation question, it really can vary. Across all of our trainings, we've trained about 2,700 people across North Dakota and South Dakota now over the last 5 years, and our average is still at about 92%. So sometimes it's staff confidence. They're really confident in how they take a blood pressure. And then when we do like a 6-month follow-up evaluation, we've done that for a couple of grant projects, their confidence goes down quite a bit, because as they sit in a room and think about the competencies, they realize they aren't doing it as accurately as they perceived they were. So honestly, all of the same kind of messages, but it could just be who happened to attend this training. So I know they all still took away things. It's just they maybe didn't feel like they could make that change, or felt like they were doing it accurately in the first place. So sorry, Katie, did you have something else?
Nope, just thank
Okay.
you for that. I just was curious if it was repeats where, like you said, if it was that confidence booster that they felt like they needed to take away less because they were more proactive now to doing the right steps.
Yeah, it honestly is a give and take, right? I mean, we feel like, oh yeah, again, we say this is nursing 101. So we go, oh yeah, I know I'm doing all this right. And then you leave the training and you go in to take a blood pressure and you're like, I just talked to that patient the entire time. I was not going to make her take her arm out of her sleeve, and her back is not supported on our workflow. So, you know, we see a lot of that, especially in, you know, kind of that 3-month, 6-month follow-up. So yeah, I think it's always a good thing. It's always a great reminder. And honestly, because it's Nursing 101, to still have 75% of the staff say they aren't taking it accurately and that they're committed to making a change is a huge deal. So we really appreciate that. And I see Geraldine had a question, and it said, if you find factors that would elevate BP, like not resting for 1 to 5 minutes, do you instruct staff to record blood pressures or just the BP that's retaken? So if somebody sits down and you take their blood pressure and we have 138 over 97, okay? So elevated blood pressure, we're gonna want to retake that. You will record it. Now this, I'm going to tell you what we suggest for best practice, but each facility is going to be different. Some facilities ask you to record both. They'll ask you to put the first blood pressure maybe in, you know, the notes section, and then the second blood pressure that was within normal range in the actual BP field. Some ask you to average it. I don't like that because honestly, most people can't just average off the top of their head, and nobody's going to pull a calculator out of their pocket to average them. Others ask you to record the lowest of both the systolic and the diastolic. So if your lowest systolic was 132 out of both blood pressures and your lowest diastolic was 72, you would record the lowest. So I would, Geraldine, suggest that you take a look at your facility's process or ask your director of nursing as to how they would like you to do that. Averaging, again, is not the best method out of all three. We do encourage documenting both, but in the field for blood pressure, we traditionally recommend the second blood pressure, because by picking the lowest of 2 different readings, that is still not the patient's blood pressure ever. So, you know, making sure that I feel like having the pair tells a better story. So usually, like I said, I recommend that we would pick the most recent reading. But again, every provider is different and every health system is different. So checking with your health system would be your best bet. But that's a really great question.
Perfect. Are there any more questions? Okay, thank you so much, Tiffany.
Yeah,
that is
no
so
problem.
exciting about that news that it's going to be on demand. I know that was like a huge ask, especially during our pilot, that those times were hard for some of those nurses to get to. So that is like,
yeah, absolutely. And we're just waiting, honestly, waiting on the IT side of getting this uploaded to train, but then also the Board of Nursing has to approve it to be continuous. And so we're just waiting on that final approval, because I don't want to offer it without CE to your staff. So nope, that's perfect. And I'm here to help if you guys need anything. Thank you.
Thanks, Tiffany. Okay, so next I'm going to share some of the data that was gathered through the quarterly reports. A huge thank you to those teams who completed that and sent it in. I would love to see some more next time. We got more this time than last time. Let's just keep our improvement going. But just a quick reminder of our NSDPQC goals. We want to see 100% of your staff trained, and that'll be much easier with that on-demand training once that hits. I want to see 100% of our blood pressure compliance, 100% follow-up, and education criteria. So I made some of these charts. As you can see, November, nobody had any of our goals met, which was to be expected. In February, if we had a few more that reported that they had actually met our PQC goals. And this month in May reported we have some more. So I like this upward trend. You guys are doing some incredibly hard work on your sites, and I think definitely worth celebrating. This next chart, even though you might not meet the goal, you're seeing improvements and increases in your trends, and we have even more of an upward slope, which is great to see. And I know we can keep working hard to meet these goals. And I'd love to see these numbers just to keep increasing through our next session. You guys have realized some really fantastic successes, and I'm excited for your storyboards later today for you to share those successes with each other. And so we can all celebrate together. Next up, we have the privilege to hear from Stephanie Ducado from Tribal Nations Research Group. Stephanie is an enrolled member of the Turtle Mountain Band of Chippewa Indians and a mother of 2 sons. She holds a BA of Psychology from University of Oregon, an MSW from University of North Dakota. She began her career as a research assistant during her time in Oregon, studying the effects of loss of federal recognition status on Native American tribes. During this work is where she was introduced to the term historical trauma and its impact on Native communities. She has also worked for Native American Rights Fund in Boulder, Colorado, which fueled her passion for federal Indian policy and the relationship between tribes and the US government. These 2 experiences have been the driving force in her pursuit to positively impact in Native American communities. She has accomplished this through 18 years of experience at the Turtle Mountain Community College as the director of Native American Training Institute in Bismarck. And more recently, she is a member of the Tribal Nations Research Group in Belcourt in North Dakota. In her free time, she likes to create beadwork and spend time with her family, friends, and travel. And Stephanie, I think we need to add some pictures of your beadwork in here on your next presentation because I would love to see it. But I will mute myself now and let Stephanie go ahead. Did you want to share your screen?
Actually, yes, let me try
Okay, I will.
Oh. Share. I'm gonna do this. Hold on, I'm getting there.
You are
How
just
many
fine.
Zoom meetings I've been on, you'd think I'd know exactly what I'm doing, but I guess not.
When the
Okay.
pressure is on, it changes.
I know, oh my gosh. Okay, what are you seeing?
I'm seeing your presentation, so you're good. I don't see your notes, so.
Okay, you know,
You're set.
okay. Okay, I don't see my notes either, but we'll get through it.
I can
Okay.
share my screen if you want to just have your notes up.
You're good, thanks.
Okay.
So thank you, oh my gosh, I need to change my bio. It's so long, but it gives it, thank you for that introduction, I appreciate that. And I will, actually, maybe I'll use my beadwork for my next PowerPoint, but thanks, Morgan. So good morning, everybody. My name is Stephanie, as Morgan stated, and I've been here a couple times in these trainings, so maybe you recognize that name. I am with the Tribal Nations Research Group, and the staff that work here on this project specifically are Molly Lilly. She's not here with us today. She helped me with the PowerPoint, and then our TNRG president, Anita Frederick. She's with us here too today, so welcome. So today we're going to talk about Native American women and hypertension during pregnancy, and I'm just going to dive right into some data real quick, some numbers, and then we're going to talk a little bit more about the whys of why this data is the way it is. So okay, now here's where I'm having it. Can you see the next slide? Okay, we're good. Okay. So right off the bat, let's talk about some pregnancy-related mortality ratios. And this information came from the Journal of Women's Health, an article that's tagged down below, maternal mortality among American Indian and Alaska Native women. So I'm going to tell you right off the bat, I say Native American, that's what I prefer. So I'm going to go back and forth, and I just like to tell audience that sometimes because there's a big question, what's the proper word to use? Native American, American Indian, Indian. So I use Native American. I'm just going to say that right now. You might, it might say something different on the slide, but that's my preferred lingo. So pregnancy-related mortality ratio among the general population of women in the US is 16.7, or yes, 16.7, and that's per 100,000 live births. For white women, it's 12.7, non-Hispanic Black women, 40.8, and Native American, American Indian, Alaska Native women, 29.7. And although it's not the highest of the groups that we see here, and there's some alarming numbers, today we are focusing on the Native American population. And one thing I just wanted to note, that education is a protective factor in pregnancy-related mortality rates. However, for Native American women, it's not necessarily. So Native women, let me move this because it's covering my notes. So Native American women with some college education still have a higher rate as their counterparts with those with less than even a high school diploma. So that's kind of a strange and quite, thought-provoking piece of information there. Why is that? Okay. Oops. There we go. So the 3 leading causes of pregnancy-related maternal death rates for Native American women are hemorrhage, cardiomyopathies, and hypertensive disorders of pregnancy. And you'll see the comparison. So for hemorrhage, 19.7 for Native American women, and then white was 9.1, and so on. And the only reason why I only included that as a comparison is that's what the article shared with, that's what the article focused on. So why is that? Why are those numbers? Why are the top numbers? Why are those the top numbers for Native American women? Well, Native American women are more likely to experience a number of disparities, including higher levels of poverty, hazardous living conditions, food insecurities, and then sexual and interpersonal violence. And we know that because of the relationship with the United States, the history of the relationship between the United States and tribal communities, that history of systemic racism includes forced sterilization, which mostly happened during the 1960s, if you want to ever look that up, infant separation policies, boarding school era, and that. So those policies that the United States had for tribal Native American tribes created a real distrust of Native Americans and their care providers and the people that they were going to for healthcare, for social work issues, for anybody that they kind of came in contact with, because all those entities were utilizing these policies that the United States put forward, and it made it difficult to establish meaningful relationships with your healthcare provider or the person you were seeking services from. And so partially because of that, Native American women are 3 to 4 times more likely to wait until their 3rd trimester to begin prenatal care. So that's a real big issue. Other reasons for that are the barriers they face to care, lack of access to health insurance, living remotely. A lot of our population live on reservations which are very remote, sparse. Often it depends on the reservation, it depends on the location, how far somebody has to travel to actually see a healthcare provider. Now, I live on the Turtle Mountain Reservation. It's 6 miles by 12 miles. It's pretty small. There's some larger ones, and people live pretty remotely, so that's a huge barrier, especially when transportation is an issue. Another one is high turnover rates of physicians within our communities. And if we have high turnover rates, we also have understaffing at our Indian Health Services, as well as being severely underfunded. Another issue is long waits. So up to 2 hours, you can wait to see a provider for 15 minutes. So because we have underfunded health services, high turnover rates of physicians, they're serving more people. We have less physicians and more people to serve. So it becomes a day-long incident just to go to the doctor. So that takes up a lot of time too. And, it takes up a lot of the day. It's a huge barrier for our communities. And so, you know, I talked about, and you heard in my bio, I'm really interested in and focus on policies that affect tribal communities, the history of it. And so we know that culture is really important to health, and it's important to our well-being as a human being. And so when we see that Native American people experience unequal rates of chronic health disease and mortality, as well as poor health outcomes, we kind of have to look at their whole situation and not just what are they putting in their mouths, how are they treating their body. It's more than just that. And so, and the result of, you know, decades of hundreds of years of colonization of tribes has resulted in a lot of culture loss of land base, food sources, language, our family structure, our community structure. And that's really vital to our mental health, our physical health, our spiritual health, and our relationship to the land that we live in. So, you know, food sources, now when we think about things like, you know, I'm going to move, if I'm living here in Belcourt, I'm going to move to wherever, Colorado. Food source is not really an issue, but the way that tribes lived within their land, it was a huge issue, because when we were moved and removed from our homelands into new areas, we didn't know the natural food sources that we relied on. So it really did become an issue. And we were put onto reservations where there were food deserts. We were given food rations, which are now commodities, that were really high in fats and carbs, and they looked nothing like the food that we were accustomed to and that our bodies were accustomed to. And it also brought diseases that we didn't have immunity to. So there was a lot of trauma intergenerationally and historically through our communities. And so in exchange for those losses, the US promised through treaties to provide health care. Unfortunately, very underfunded, and it lacks sometimes the services that we need in our remote areas. And I know that rural America experiences very similar issues with healthcare. So it's not just an issue within Indian country or with tribal communities. It's an issue across rural America, having access to good healthcare and the services that we need. And so we know that trauma plays a dangerous role in our health, and that culture is really important. So I don't want to paint a real negative, paint me into a negative corner about talking about our communities, but because we are beginning to understand, well, we kind of knew that, I think, in our communities for a long time, but there's a boost in tribal communities to really take a look at how culture plays a part in our health, and taking kind of control of that and bringing that back into our daily lives. And so it's become really important to our communities and to probably patients that you're seeing. And so we are moving towards, we're beginning to understand that and move in a more positive direction. That's what I want to make sure to communicate here. And so what are some policy recommendations to address these issues? These healthcare issues in our community. So the first one is adequate funding for Indian health services. That's what IHS stands for, if you're not sure of that. Between 1993 and 1998, IHS appropriations increased 8%, while medical inflation increased 21%. So we know right there it was underfunded right off the bat. And in that same time frame, actually 1990 to 2000, according to the Census 2000, Native American population increased faster than the total population. So you have funding that's not meeting the national standards, and you have a population that's growing faster than the rest. So it just creates even a more imbalance. So adequate funding for IHS, developing collaborations between American Indian, Alaska Native, and other stakeholders. And this grant partnership with NSDPQC is a good example of how to do that, how to, it's a good start. And so there's lots of examples. It's happening more and more, and we're starting to really build relationships across the table. So addressing social determinants of health. And so we talked about, why are we in these situations? And we're doing that within our own communities. We're addressing those social determinants of health. We're addressing our own You know, like I said, bringing that culture back, bringing those healthy lifestyles back, and really focusing on that to help the issues that we face in our communities. Support federal, state, and local policies that are responsive to American Indian needs. So, you know, addressing that chronic stress of poverty, racism, having an adverse has an adverse effect on our health outcomes, inadequate housing, lack of needed resources, and again that historical trauma. And then expand and protect access to trusted community-based healthcare models. And so there's a lot of examples out there of community-based healthcare models. You probably know more than I do. You're the experts in these fields. But part of that is, you know, working with that community. And so as I say, you know, we're bringing back our practices and we're trying to, you know, the health benefits of that, trying to realize those things in actuality. And so a community-based healthcare model can honor that piece with that patient. So if somebody, you know, encourage, where am I trying to go here? Honoring cultural birth practices is part of that. You know, talking with the mother, understanding what they're doing, culture that's cultural based to ensure that they have a healthy pregnancy and a healthy lifestyle, and making sure to incorporate that and understand that in their healthcare process. And I also provided a couple sites at the bottom of this one, this slide for where you can go for community organization models. It's the Rural Health Information Hub, in case you don't have that. And so that's kind of, sorry, I'm trying to maneuver too many pages, too many, where's my Zoom people? Okay, so this is the pamphlet that part of our partnership in this project is reaching out and working with the tribal communities in North and South Dakota, I'm sorry. And so we decided that we wanted to come up with a little pocket pamphlet. If you were here the last time I presented, we talked a lot about patient education, because that is, even when the first presenter was talking, I thought, you know, when I first read those guidelines for having your blood pressure taken, even that made me more aware. So when I go to the doctor, I know I need to sit right, I need to keep my feet flat, not cross my legs, I need to be quiet and let them do their job while they're taking. So patient education is really important too. So I know, and I'm being a good patient when I'm there. So we decided we wanted to develop a pocket pamphlet for patients, and to help guide them through that, you know, this part of their care, and just kind of, you know, asking, what is hypertension, what are some symptoms, giving them some information and answers to those questions. So it's we haven't, I don't know if she's actually printed it yet, but we plan for it to be like just a small thing that they keep in their purse or their pocket. How can hypertension affect pregnancy? Some information on what that means, what the words are, you know, the lingo, preeclampsia, all that good stuff. What can you do? And how can I manage it for myself? And, you know, some questions that they can ask while they're there with the doctor. And then we also included this is all Molly, by the way, she's fabulous at doing this stuff, but a little blood pressure card for them to carry with them, just kind of some information about, you know, what each number means, and then a blood pressure log for themselves. Myself, I'm pretty aware of what my average is over the years. So I kind of I know, but some people just, that's not their, you know, they're not interested in that, or they haven't been told what their blood pressure is. Sometimes you go and the nurse maybe just writes it down and moves on. And so this is something to encourage them to keep a focus on, and be aware of what their blood pressure is throughout their visitations, throughout their pregnancy. So that's some stuff that we're hoping to share, and we'll make sure that everything is correct on those pamphlets, and you might be seeing those in your community soon for patients. And then, are there any questions? This is some references, some the articles that I used for the presentation.
Actually, Stephanie, I'm going to ask if everybody can hold their questions for you, since you're going to be in one of our breakout rooms.
Oh,
they
yes.
can ask you in their smaller groups. But thank you so much for your presentation. It was wonderful.
You're
Now, I gotta
welcome.
say, I feel like I'm a more informed patient too. Every time I went into a doctor's office, I felt like I need to like fill the silence with chit chat.
Right, right.
Not
Like,
feel
just
so
don't even talk to
awkward.
them.
So now I know to keep my mouth shut.
Me too, me
while
too.
They're doing
Thanks.
that. But thank you so much, Stephanie, and we will see you in a breakout room shortly. Next up, let me get my screen back up. We are going to hear from Krista Fremming. She is the Assistant Director of Medical Services Division for the Department of Human Services in North Dakota. In her role, she oversees the Managed Care in Children's program, and she has been with Medicaid for the program for nearly 5 years. And prior to that, she worked in public health and chronic disease and prevention programs.
Hi, everybody. Can you hear me okay?
Yes, we can.
Okay,
just like one of my windows. Okay, we're good.
All right, thank you. Yeah, I'm really happy to be here with you all today, and it's great to learn more about the work that this group is doing. I had a conversation a couple weeks ago with Morgan and Dr. Andrew. Gosh, why can I not remember his last name? Williams, yes. And thought that it would be really relevant to talk with this group about just kind of the scope of the population that Medicaid covers in pregnancy and postpartum, and our targeted case management program for high-risk pregnant women. We revamped it a couple of years ago, the case management program, but we really haven't seen the uptake of providers enrolling to do the service and members receiving the service. And so I think that this group may have some ideas around that. So if you want to advance the slide, Morgan, just so you have a context, North Dakota Medicaid covers about a quarter of the births in the state. You can see the data from the past few years here. Go ahead to the next slide. And so I really, knowing that Medicaid covers a quarter of the births in the state, wanted to talk with you all about Medicaid coverage for targeted case management for high-risk pregnant women. I put a link to the policy on there so that you have that and can refer to it. We, like I said, really are hoping to get more providers to do this service. It's intended to assist high-risk pregnant women with achieving healthy birth outcomes and preventing future unintended pregnancies. And this is done through, meetings with a case manager. They do not all have to be in person. I know that a lot of them are done via telehealth nowadays, especially. So you can go to the next slide, Morgan. So this is I know this looks like a really long list. This is who qualifies for targeted case management. And I guess I just want everyone to understand that it's pretty broad. We're trying to cast a really wide net in terms of who would qualify to receive the service, because we know it's so important. So any one of these risk factors, and I think particularly maybe the third one towards the bottom, as you think about the Medicaid members that you're serving who have high blood pressure. We've been talking a lot about high blood pressure over the past hour, but any basic, any chronic condition or condition that a physician has certified that could result in a high-risk pregnancy for the woman, that would be that would all be appropriate for that woman to receive targeted case management. And then if you go to the next slide, if the person doesn't have one of the risk factors on the previous slide, if they have 3 or more from this one, they could qualify as well. And so I believe that I guess it's hard to know the exact percentage or number of pregnant women who are covered by Medicaid who would qualify for this service, but my guess is that it's at least half. I think we could pull some data to get a more precise number. You all may have some thoughts on this too from what you see in your clinical practices. If you can move to the next slide. So this is what I really want to highlight to you all, because I think this just shows the opportunity. Over the past 3 years, these are the numbers of women who have received this service. And so we're not providing services to the case management services anyways to the women who need it. And it's a reimbursable service. I think it would fit in very nicely with I know they changed the name. It used to be called Baby and Me Tobacco Free, but a lot of the birthing centers I know partner with the health department on that program. And all of those women would qualify for case management, and case management is, a little bit more general, doesn't have to address that tobacco use. So yeah, just wanted to talk to you guys about the need and how we might be able to grow this. If you can go to the next slide, Morgan. Just on the provider enrollment side, there is a specific taxonomy for case management services. And so that would have to be, you'd have to add that to your existing billing group, or if you're not an enrolled Medicaid provider already, get that established. I see a question in the chat about, does targeted case management have to be requested or initiated by the provider? It does, because you have to, there's an assessment that you would complete to determine if the woman qualifies. It's very brief, and then that is submitted to the state, and then you can bill for the services, and the codes and more information along those lines are in the policy as well. But Colette would be happy to answer further if you need. Morgan, if you can go to the next slide. Okay, this is the last one. Yeah, so just wanted to open up the floor for questions, thoughts, ideas, links that can be put in the chat. Yes, I will put the link to the policy right in the chat here. That's a good idea. And the other thing that this group should be aware of, you probably are, is that Medicaid will be expanding postpartum coverage. Currently, we only cover pregnant women through 60 days past the birth of the baby. And then if they no longer qualify for another category of Medicaid, then they don't have that coverage anymore. We will be extending that from 60 days to 12 months, which is awesome and is going to, I think, do a lot of good. But at the same time, we want to talk about how we can serve these women more comprehensively and get to the outcomes that we all want. So I will stop there. When is that expansion going into effect? We are planning to have it be effective January 1st of 2023, so in about 7 months. There are some changes that we have to do to our state plan and our IT eligibility system. So we're working through all of that right now. But yes, it's really great news. This is like probably the best thing that's happened in the Medicaid world and in my book in a while. So
Perfect. Are there any other questions for Krista? Oh, do you know if South Dakota is doing that as well?
Oh, the postpartum coverage extension. I don't know that. You know, there's been a lot of talk about this nationally because this legislation was tied to the ARPA funds, the American Rescue Plan Act. I think that's what it stands for. So a lot of states are expanding their postpartum coverage, but I just don't know if South Dakota is one of them.
Morgan, this is Dr. Carpenter. South Dakota does not have an expanded postpartum coverage at this time.
Perfect. Thank you. You are the person to ask. So that would be on here.
And, you know, if there are other groups or individuals who should receive this information, please let us know, because as you can see, we really need all the help we can get with getting more providers to do this service. So would be happy to take any of that type of feedback.
Thank you so much, Krista, for being here with us today. I knew when I met with her a couple weeks ago, she had some great information and I really wanted to get her to share it. So thank you for like the short notice of throwing this presentation at you.
Yeah, of course. Thanks for having me.
All right. So next up, we are going to hear from Sarah Razier. Am I saying that right? I hope I am. I haven't met her face to face yet, so.
It's Razier, very close.
Razier. Okay, well, she is from Altru Grand Forks. If you remember last session, we tried to get Sarah's colleague Melissa to present, and she ended up having some travel issues because of the Midwest weather. And luckily, there's some other issues that we couldn't get Melissa, and so Sarah got this really last minute, like within this last week, to share with us today. So really grateful and appreciative that you were willing to do this and have it thrown at you. Sarah is a 2006 graduate of the University of North Dakota with her BSN. She has worked with Altru Health Systems for 15 years and has experience in inpatient telemetry, critical care, home health, and most recently, the supervisor of population health in the outpatient case management department. She oversees several different programs, including prescriptions assistance, disease management, education, outpatient social work services, tobacco cessation services, Altru's home visit program, and the remote monitoring program, which she's going to present on. So I will stop talking and I'll let you take it away.
Perfect. Thanks so much. I have a huge passion for our remote monitoring program, so I am happy to share, even if it's last minute. So I have about just the next 10 to 15 minutes to talk about our program and how we expanded into our OB patient population. Just a quick overview of our objectives, review our program, the basics of our equipment, how we integrate it into the care of our high-risk OB patients, and then of course what barriers and benefits we've seen so far, and just a couple outcomes. This just shows a good visual of our equipment. For our vendor, they're currently named ClearArch Health. They've had a few name changes in the recent past. Originally when we went up with them, it was Honeywell. And they happened to be just kind of the top vendor that serviced our area. They were excellent to work with. They did on-site visits with us. They even came into patient homes when we set up our first few monitors to show us how to run everything, how to educate the patient properly and whatnot. So our piece of equipment here, it's a basic Samsung tablet. And then our peripherals that we use currently are a scale, blood pressure monitor, and oxygen pulse oximeter. These all pair using Bluetooth technology right to the tablet. And then that tablet uses cell phone tower transmission to send the results back to our dashboard. So there's no relying on the patient's Wi-Fi. That's a common question we get from patients. And we found we've gotten very good service, even in our rural areas. I believe they use Verizon cell towers. So we have found very few areas that we don't have service for. ClearArch also has a web-based software for our clinicians to use. It used to be a desktop app, which means you had to be on your certain computer every time to use it. Now it's web-based, which is excellent. Their software is HIPAA compliant. So when we set up an interface with our EMR, everything was good to go because of that. We use Epic, obviously, for our EMR. So our interface has been great. The results from the patient's readings go right into their Epic chart as well. We initiated our program in 2013 and originally started with just 15 monitors. And we were solely focused on CHF patients at the time. Now we've expanded. We have over 100 monitors and have expanded the diagnoses we focus on, such as COPD, sepsis, pneumonia, still doing heart failure, COVID, and hypertension, and now our OB patients. And we've always focused on high-risk patients with an overarching goal of our program to reduce hospital admissions. A little bit about the structure. In January of last year, we were able to justify hiring a full-time RN that's solely dedicated to our program, which is Melissa, who's going to present. So that was a great growth. And it also gave us opportunity to grow even more. One of the keys to success of this program is our home visit program. That kind of gives us our method to get into the homes and set up our equipment and show patients how to use it. This program is non-billable visits in the home, and we mainly focus on patients that are leaving the hospital, but we definitely see any referral that comes our way for maybe just somebody, a general outpatient that is struggling with something in the home. We have a very strong partnership with our home health department. They have 3 branch locations, which gives us a method to get out to our rural locations. All of their staff are also trained on our equipment, so they're able to go out to the home to set it up as well and then help the patient through any questions. We have probably about a 100-mile radius that we serve by utilizing our home health partners right now. We provide monitoring 7 days a week. So our main RN is our person during the week, and then we have just a basic weekend rotation and holiday rotation with the rest of our staff so that we cover every single day. Currently, we are not charging for remote monitoring. Of course, there's CMS codes that you can drop, but we have found that reimbursement is kind of mediocre for the work you have to do. And we didn't want that to be a barrier for patients accepting our services. With our goal of preventing admissions, we want to do everything that we can to make that patient successful. So we didn't want cost to be in the way. And most payers do leave a copay for the patient to be responsible for. Next slide. So kind of how we embarked on monitoring our OB patients, our vendor had presented a study to us that we kind of looked over and then did more research afterwards, which was really hard to find really anything out there about monitoring OB patients. The study was done by the University of Wisconsin in a hospital in Madison, and they mainly just focused on the feasibility. Would it work to monitor these OB patients? Would they be satisfied with the monitoring, and could you keep them out of the hospital? All their participants had some sort of underlying hypertensive disease during their pregnancy. And they had really good results, actually. It was a smaller study. I think their total participants was 55 patients, but they did have good results. About 16% of their patients developed severe hypertension after hospital discharge, after delivery. And most commonly, it occurred in that 5 to 6 day time frame. And of those, 45% of their participants, 45% of them required some sort of intervention or treatment for their blood pressure after hospital discharge, whether it was starting them on a new medication for blood pressure or titrating or increasing their current meds. They had no hospital readmissions of their patients they monitored, which was excellent. And they really felt that the early and prompt treatment of the high blood pressure was key to the success. And then with their patient satisfaction surveys, 87% of their patients were either very or extremely satisfied. So we kind of use that as our mode to move forward. We did our own research again, like I said, and there really wasn't much out there. So we reached out to our own OB staff leaders and some of the staff involved and just kind of presented the idea. They were very interested, so we kind of moved forward. One of the big keys, of course, to our success was having physician lead, which is Dr. Lessard. Getting provider buy-in is huge to being successful, so she helped lead the way with that. And then we presented at our med staff meeting and staff huddles. We brought the equipment, showed it to the staff, showed them how the patient would use it. gave them tip sheets, gave them all the information they needed to kind of feel comfortable with the program. Next slide. Again, we focused on our high-risk OBs. We basically are having provider-led patient identification at this time. We aren't limiting to just postpartum, similar to what the study did. We're doing pre and postpartum at this time. Obviously focusing on patients with preeclampsia, previous high-risk pregnancies, a diagnosis of hypertension or pre-hypertensive already. And then we are not excluding patients based on their locations. If we have a referral, we're figuring out how to get out to that home and get the equipment set up. We've seen patients so far that live 2 hours away, so we have a really long reach right now. One thing we've tried using, and we haven't been too successful yet, just due to some staff changes on our inpatient team, is a risk dashboard that the inpatient team uses. I think in the future, this will be a good way for us to help identify some patients that would benefit from monitoring. We're just not quite across the street at using that yet. So something to work on for us. Next slide. So what our process looks like, it starts with an order being placed in our EMR, which triggers a work queue. We have a nurse who monitors that daily. And then we also do rely on direct communication, especially for those patients who either might be leaving the clinic or leaving the hospital soon. We kind of need that phone call to run up there and get the patient taken care of. And then we communicate with the provider or the nurse. Things we need to know is how often they want them checking their blood pressure. At this time, most of our providers are wanting them to do it twice daily, depending on their risk. And then placing that order, some of our providers are still needing help with that because it's so new to us. That order includes parameters for when our providers want to be notified for their blood pressures. So we've been helping them get that order in. Then we make contact with our patient, set up a time to meet them, whether it's running up to their hospital room, running to meet them in the clinic while they're here for an appointment, or doing home visits, which we always prefer. It's great to get out to that patient home. Next slide. Meeting with the patient is heavily focused on education. Obviously, we train them on using the equipment. Each of our clinicians and nurses have a checklist that they need to go through with the patient to make sure we cover our bases. Most importantly, getting an accurate blood pressure is key. We are extremely careful to make sure we get an accurate blood pressure and that patient is independent in testing their blood pressure at home. We measure their arm circumference, make sure the cuff that we're giving them fits appropriately. Our vendor supplies different size cuffs, so we're able to make sure we have the right one and get a good reading. And then we usually compare a manual versus the monitor that we're giving the patient, just as a double check to make sure everything is accurate and good to go. We always make sure the patient can return demonstrate to us and that they're independent before we leave the equipment with them and let them head out. Some of our key focus for education is making sure they're sitting and resting prior to testing. Their feet are flat, those basics of getting an accurate blood pressure. And then a review of contact information. We have to be able to reach our patients, and sometimes that can be a barrier. So we make sure that we have the accurate demographics and that those patients have our contact information as well. Next slide. This is just a snip of what our actual dashboard looks like. And this was an actual OB patient just from a couple weeks ago. The dashboard has some color coding. The red obviously is an alert that shows us when that patient's blood pressures are outside of what the physician has ordered. So it's kind of great to alert us right away. It also lets us know if the patient didn't test when they were supposed to. So those empty packet alerts that you see there means that they didn't send a blood pressure through when they're supposed to. So we might be sending a message to that patient's tablet, giving them a reminder to test. And if by the end of the day they don't send something through, we're almost always calling and reaching out to them. Kind of our way to make sure everything's okay and to show our patients that we're watching things very closely. When we do have to reach out, we're asking about symptoms. If they have a high blood pressure or if they have symptoms, either one, we're calling the OB provider to get further direction on what they'd like the patient to do. We're typically monitoring until that patient is stable in the postpartum period or when the physician wants to discontinue monitoring. Figure out a way to retrieve the equipment. It's either running out to the patient's home or we have a lot of patients in our rural areas that will just drop off their equipment at the nearest Altru location. to them, which works perfect, and we can get it on the courier back to us. One thing we've started doing is providing each of our OB patients with their own blood pressure monitor to keep when we pull our equipment out. Our system has been focusing on increasing our patients who self-monitor their blood pressure just in general. So we thought this would be a great way to start some of these young moms out the right way earlier in life. We did apply for a grant and were awarded dollars. So we've used those dollars to purchase quality home blood pressure monitors that we give to these patients, with the hopes that they keep monitoring in the future. Next slide. Of course, you'll have some barriers, and cost seems to be the biggest one with this program and equipment. Each set of equipment can range from $800 to $1,200, depending on which peripherals you're ordering with it. And then not only that, but each set has a monthly data fee for using cell phone tower transmission. So that's about $31 per tablet that you're paying as well. We heavily rely on grants to purchase all of our equipment. I don't think we've spent our own dollars on any of it. So we're constantly looking for opportunities to do some grant programs to help grow our program. And then of course, staffing. Once we moved to a specific nurse dedicated to our program, that added additional cost as well. To be completely transparent, staff and provider engagement is a barrier. It's new technology. We have some providers who kind of refer to us as the middleman, which is true, we are the middleman, but getting them to see the benefits and things like that is something that we're working through. Patient compliance is always another barrier. Some patients kind of drop off the face of the earth. They quit testing, they quit answering their phone. We find ourselves running out to patients' homes at times to check in because they've kind of, just quit communicating with us. So that's always something that comes up, not very often, but it definitely does. And then just the logistics of having equipment in patient homes, especially in our rural areas. How do you get that equipment back? What if something comes unpaired with a tablet? How do you walk that patient through it? Or do you need to send a clinician out to the home to help fix it? Different things like that, and mileage to and from that patient's house as well. Benefits, definitely more benefits. Clinician oversight. We have really noticed that some of these patients really downplay their blood pressure readings and even their symptoms. We've had several that wouldn't have sought treatment had we not reached out to their provider and encouraged them. Saving a patient a trip to the clinic. We have so many rural patients, so they have been really grateful to have somebody communicate with their provider, have somebody watching over them to save them a few trips in. And then obviously quick intervention. We're catching things immediately as they happen, notifying the provider immediately and getting meds titrated or whatever needs to happen in a much more timely manner than just relying on the patient to report it. Decrease in patient anxiety. We've seen this with not only our OB patients, but all of our patients. With the health problems that a lot of them have, they are so anxious. So knowing that they've got, a nurse watching their results every day or checking in on them daily if need be, we've had several comment of how much that puts their mind at ease. Opportunities when you get into patient's home. I could go on and on about the importance of getting out to that patient's home. We have found so many things that you would never know unless you got out there. You gain their trust. They tell you more once you get out there. Specifically, we had one of our OB patients, after we got out to the home, realized she had food insecurities. She didn't have hardly any food in the home. She had several children already. So we helped her get food baskets to get signed up with the food pantry. She also had transportation barriers, so we're helping her make sure she gets to her appointments and providing bus passes or whatever she needs to make sure she's coming in for her care. So getting out to that home is so important. Possible reduction in hospital and observation stays. We haven't been able to quite measure that yet. We're hoping to in the future, but we feel with acting quickly that we're definitely preventing some of those right now. And then education on self-monitoring of their blood pressure for the future. As I mentioned, we're really working on that as a system. So starting these patients out young is excellent. And just engagement, patient engagement in their healthcare. For some of these women, it might be the first time that they're doing something at home to help themselves with their healthcare. So that's another great benefit. Next slide. Outcomes. So we've been finding data retrieval is difficult. We've been asked what we're going to monitor, and it's kind of like, we need to figure that out. Our software currently relies heavily on our input of manual data, I guess, basically. So we would have to manually input whether or not that patient was admitted to the hospital or things like that. So we are working on that. We don't have much data for readmissions right now that we can rely on without doing it all manually. So we're hoping to get that in the near future. We have monitored 33 OB patients so far. We started our grant period in October of last year, and we set a goal to do 5 new patients a month. I would say we're not quite to the 5, but we're close and a little over some months. But we'll get there. We're hoping to eventually grow the program, of course. Positive patient outcomes, just a couple examples that I had written down for recent patients that we've been helping. One of them actually just last weekend, we had started monitoring her probably a week prior. She's 32 weeks gestation. She has a history of preeclampsia. She developed high blood pressures over the weekend, and this was after she was already discharged from the hospital for blood pressure monitoring, had vision changes and things like that. But when we called her, she was, nope, I feel fine. It's just amazing that, you know, the patients know they have high blood pressure. They can see our reading, we can see their reading, but they truly, a lot of them do ignore it. So she was very hesitant. We'd already called the on-call provider, and it was recommended that she come into the hospital to be observed. She really didn't want to, but we're finally able to convince her. But she's still in the hospital. She's on MEG. She's increased labetalol. So just one of those cases that you wonder what would have happened had we not convinced her to come in right away. She probably would have waited if it was just up to her own monitoring. Another high-risk patient that we have been monitoring since she was actually 12 weeks gestation. She has a history of a stroke. I think she had a pseudoaneurysm in the past, and then had a diagnosis of pre-hypertension, so very high risk. Again, we started monitoring her at 12 weeks gestation. She just delivered about 2 weeks ago, and was home and started monitoring on her remote monitor again. So we were monitoring her daily. And at about that 6-day post-delivery timeframe, which was very similar to what the study had found, she had a spike in her blood pressure. So I was actually monitoring her that day and called her. And again, she was one of those patients that was, I feel fine. I don't have any symptoms. You know, everything's fine. She wouldn't have called her doctor had we not been monitoring her. So I reached out to the provider right away, and we increased her labetalol that she had already been on. The next day, she started developing symptoms, had a headache and vision problems, and did wind up in the ER, but she was able to be discharged home. Had we not intervened right away, maybe she would have had to have been admitted. It's hard to say, but definitely taking that quick action seems to be key to keeping them out of the hospital. And next slide. That is really all I have. I included a link to that study that our vendor had passed on to us for anybody who wants to take a peek at it. They, of course, used our vendor's equipment, so that's kind of how we got wind of it, but it is a pretty good study, even though it's a small sample size, and has some good information on the benefits of monitoring in the postpartum period. And I believe I'm in the question group as well, so I'll leave any questions for them.
Perfect, thank you. And Sarah and Dr. Lessard will both be in that room together, so we'll have both of you guys to help answer questions. Okay. So next up, I want to introduce you to Carrie Redmond. For those of you who are with us during our pilot last year, you may remember her and her colleague, Amy Ladley. Carrie and Amy are both from the Louisiana PQC, and they have been incredible mentors and champions of the NSDPQC. And for Carrie, she is the Perinatal Quality Improvement Advisor for the Louisiana Department of Health Bureau of Family Health Perinatal Quality Collaborative. Carrie comes to the team as an experienced nursing clinician of 25 years and previous women's service director of a level 3 facility. And before her transition to the Bureau of Family Health, she served on the committee that brought the development and building of a level 3 women's health center, and a team lead for the designation and of the second baby-friendly hospital in the state of Louisiana. Carrie has been engaged in Louisiana State's improvement initiatives as a nursing leader for several years, and both the Louisiana Department of Health and the Institute of Healthcare Improvement. As the perinatal improvement advisor, Carrie works closely with Louisiana state birthing hospitals as they use quality improvement to test and implement new processes, use data for improvement, and provide equitable, dignified, and evidence-based care. And Carrie, I will turn it over to you.
Thanks. If you will stop sharing, I'm going to share my slides because I had to change one slide. It's terrible. I know. Sorry.
That's how it always goes. I feel like
I'm
when
like,
presentation last week, it was like I was sending 3 or 4 different.
I was like, and I was not going to send that this morning and stress everybody out. Okay, I can talk a lot. So give me a little cue and be like, okay, hurry up, your time's up. So I'm going to get started quickly.
And you're in one of the breakout rooms too, so you'll get more opportunity to talk over the next hour.
Sounds good. So I'm going to talk a little bit about the work that we do and how you can use quality improvements to sustain your changes. I loved all the presentations. I appreciated them. I learned a lot. I wrote a couple of things down. But I do come from the Louisiana Perinatal Quality Collaborative. You can see here we are focused on QI methodology. We do use the Breakthrough Series model, the IHI model. We modify it a little bit, and we are a very high touch PQC. So a couple of things that are a little different. We do promote safe, equitable, and dignified birth. So that is our vision. We were established in 2018 and we were actually legislated. So not very many PQCs get to say that, but I hate to say it, but we were so bad in our state that we had to be legislated. So we do fall within what we call the Bureau of Family Health and the Office of Public Health. So a lot of times people will think, oh, they're coming from the state or the government, but we do reside there. We have 44 hospitals. We're excited. We've added a couple lately, and that covers about 96% of our births in Louisiana. And again, we use that QI methodology that focuses on collaborative learning and coaching. These are some of our initiatives. We've actually added another one that's not on there. It is a perinatal depression screening, which is going to take place, sort of a pilot taking place in some pediatric clinics across our state. But you can see that we have our GIFT program, which is our breastfeeding, chest feeding, neonatal designation, our Safe Births initiative, again, focused on hemorrhage, hypertension, and primary C-section. And we also have a designation, both the GIFT and a Safe Births designation program. And then we also have our ISED program, which is improving care of the substance exposed dyad. We do use an approach that has lots of things, and we call that our zucchini bread approach because there's lots of things that you put in that, right? And so when we work on developing an initiative, we think about a lot of things. Recently, including CMS, who's come out with their own agenda and things that they are requiring as well. But so we try to really think about, what are Joint Commission requirements? What are things that the teams are already working on related to QI? We always work with our teams related to the AIM bundles as we develop our change package checklist and our measures. Equity is baked in everything that we do. So we look very closely at disparities. We also stratify all of our data that our teams submit. And then again, payer initiatives are another influence, as well as state requirements. And we just changed our levels of care, and that will be coming out soon. So there'll be a little bit of changes related to obstetrical levels of care. We do really base our work on 5, fundamental principles. And again, we use the model for improvement, but I think it's really important to always think about the why behind this work. And that's so important from, whether you're getting a administrative sponsor, physician sponsor, all the way down to, your frontline staff. And what is your feedback mechanism? Because as IHI always says, how will you know when change is an improvement? So really thinking about, what will we look at to see that change is an improvement? Again, developing the change. I heard PDSA today already. We love PDSA. It's our teams laugh a lot because we talk a lot about PDSAs and small tests of change as you work towards implementation. And then knowing when and how to make that change permanent, and where, when is it permanent? How do we monitor it once we really have sustained our gains? We have some teams that have done that in our collaborative, and just as a sidelight, in order to be thoughtful about a lot of burnout that's going on, of course, across our whole nation. We have some teams that have really sustained their gain. And if they've sustained their gain in hemorrhage and hypertension, we're now allowing them to report quarterly on some of those measures, which actually, to tell you the truth, we did. We reached out to them, we did this big project, and the teams are still reporting monthly that we said, hey, just report quarterly, you're sustained and you have implementation. Really effective teamwork is important, right? So really thinking about highly reliable teams or highly effective teams. These are some of their traits. Most of these teams are, really responding to acute situations. So thinking about how do I reduce errors and improve outcomes or enhance satisfaction, which takes a lot of effective communication, really making sure that there's that comfort among all team members. Everybody can speak up. What is that culture? Really understanding, again, roles and responsibilities. Speaking up equitably is something that we talk about a lot. Who are you hearing from? Are you hearing from your team and from your patients? And we do something in much of our work called an equity pause. And that equity pause is, are we feeling that we are equitably hearing from everybody, whether it's in your team or whether it's from your patients? And what is that, are we getting inclusion as well? And we include that also. We have a drill handbook, and in our drills for debriefing, any event or any drill that you do, equity pause is part of that. And we have some, just a few elements in there that the teams can use. So again, really being, really thinking about that situational awareness. What are your operations, incorporation of team debriefing, of course, to, really look at, approaches to your processes, enhancing care. And then understanding roles too of human factors. We'll talk a little bit about that, like management styles, culture of the units, and performance. And then what is ineffective change? Well, really, I think, ineffective change is sort of doing more of the same. So a lot of times, again, I come from healthcare. I still work in healthcare occasionally. I do PRN work or flex work, but change is not more of the same. Like, we'll just put some more staff on that, or we'll put some more, we'll get some more equipment for that, or add another rule or another policy or something like that. So, and also waiting for the perfect time. There's never a perfect time. And I have to be reminded myself of that often, that there's never going to be that perfect time. And then a change that's not detailed enough to test. So everybody has to understand what you're testing, right? If you're going to do a test of change, like what is the who, what, when, and where? If you're going to PDSA something, if you're working on hypertension or skin to skin, I like to talk about that one. When I was a nurse director, we were going to work on skin to skin, and it was kind of like, tomorrow we're doing it. Everybody does every delivery, just put the baby skin to skin. And it was a disaster, and it was really bad. And we had to do like a lot of backpedaling. I wasn't really good at quality improvement back then. I didn't know how to do small tests of change, and it was a huge fail. And so I learned a lot more about that and how to do, how to get that buy-in and how to be a lot more clear in my testing. Again, we talked about how change results in improvement and how you will know. And I think it's important to really think about, a system as sort of that interdependent group of items and working together. It's people, it's processes, it's that purpose. So when making a change, we have to consider, who's in the system, like what is the input, what are the steps, what are we looking at, for outcomes. I put a few little examples in there around, hypertension. And I think creative thinking is really important, thinking about that between your task force. So really evaluating, what's that purpose and maybe what are the challenges that we're facing. If we have a process, is looking at the process and thinking, is there anything that's limiting us in this process? Could it be expanded? Do we need to eliminate something? Do we need to change the way we're doing something? You guys talked a lot about processes and really important things around hypertension and measuring blood pressures. And I think to me, that kind of goes in here, what steps are important, what's maybe not necessary any longer, what's ideal. And then possible alternatives in that situation. So how do you adapt those good ideas or those best practices in your situation? I also really think I put listserv and other hospitals and colleagues, because when you're thinking about testing something or changing, I think it's always good to reach out. I have learned that in my lifetime. It didn't take for me to come to the LAPQC to do that. And many of the teams that I work with in the state, I already know them well because I reached out. I'm like, are you doing this? because I think you said your outcomes are really good. So what did you do? I don't see any reason to reinvent wheels when they're working well. So I have no problem reaching out to somebody else or another PQC or experts. I rely a lot on our faculty to reach out to them as well. Peter, who's on the call, we appreciate him so much. Dr. Van Erden has been great for us, and we've done a lot of learning with him as well. So reaching out to those experts is really important. This is that small test of change. We talk about PDSAs. Our teams like kind of cringe with PDSAs. It's really important to our team, and we talk a lot about it. So how can you use that small test of change to really stimulate change, especially for naysayers, because you really have to have that proof of concept, and it helps get buy-in instead of, again, like I said, changing everything tomorrow, like tomorrow we do this. So it can help you with that proof of concept. It helps. It also it happens, we're always PDSAing. And so I think it sort of helps team members realize, like, we're always working and changing something. As a nurse, I'm always thinking about, I got to move that, or I don't know where that is. So that process isn't working, or we really need to make sure that this is in the room. If we're going to, where I'm from, if we are evaluating a blood pressure and it's severe, within the 15 minutes, we have to then get a manual pressure. So I don't want to run and find the manual cuff that's over on mother baby, and maybe I don't know where it is. So I need to make sure that everything is in the room so that I can quickly do that and make sure it's there. And it actually took like a really bad situation for us to realize that. So we're always, I think, PDSAing, and you need, and again, doing it very small, like, 1 hour, 1 shift, 1 delivery, 1 doctor. We try to help our teams understand that. And it also really helps you understand where the quicksand is and who your champions are. One of our coaches is really great about sort of reeling teams back in when they're like, oh, well, we're gonna make a policy on that. And she always tries to help them and say, before you make the policy, you might want to try that out. You might want to test it first and see, is that going to work? Does that work in the workflow? What do your patients say? What are your staff and providers saying? And then again, not waiting to test for that right time or getting it in the EMR or the right day. It's never going to be right, especially right now in healthcare where everything feels, kind of hard. And so again, if it feels, if you keep pushing it down the road, or I say kicking the can, it gets easier and easier to procrastinate. So how can you test something small right away? These are just the test cycles. I think it's always good to kind of remember that you start small, you adopt, abandon, or adapt, and then you finally end up with that scaling up of that process or implementation of the process with less risk when you sort of start small. Prioritizing change ideas is important. We use what we call a change package checklist, and the change package checklist, we created change packages and nobody looked at them. But when we put them in a checklist, I felt like the teams used them a little bit better. They were more apt to say, well, I'll pull this and kind of take a look at it. And we still work on our change package checklist and try to make them sort of minimize them, but keep the best practices in so that they're easy to use and our teams can use them in the work that they do. This is just a really quick example of a team that implemented shared decision making. But what I like about it is it has all the elements of quality improvement, right? And you can see that I took some of it from ARC, and so quality improvement, again, starting with that buy-in, that leadership buy-in. A lot of times we try to do this without having that champion or sponsor. And I think in the second piece you can see here, remember your cast. We use cast a lot. So who is the champion? Who is your agent, your sponsor, and your target? Your champion is that individual who believes that change, believes in the change, but they might not have a lot of authority. Maybe it's a nurse manager or something like that. Maybe there's not a lot of authority, but then your agent is the individual who becomes responsible for, implementing that change. And then your sponsor would be that administrator or that physician champion that you get on board. And then the target individual, of course, is that target population. And one thing that I'll say about this too, is that you have to remember that, task force might change sometimes. So, if you are implementing, say, shared decision making, what does that task force look like in comparison to maybe the hypertension workflow, or maybe you're doing something in NICU? I'm jumping to a whole nother place, but your task force might move around a little bit. There will be You know, there'll be that core, but who are the other players that you need, I think is always important to understand. And I think you have to really think about how you select and tailor your approach to your unit. Every unit's a little bit different. And when we talk to our teams about different things, I think labor admission policy is something everybody's working on right now. For everybody, that might look a little bit different. You know, how do you get everybody on board? How do you meet with your physicians? And what does it look like in your hospital? You know, do you have a place that your, you know, patients can even walk around, or is that even allowed right now, you know, to walk around and then be rechecked? You know, 6 centimeters not reasonable, because again, the patients can't walk around and recheck, and we're not sending them home because all of our patients live 1 to 2 hours away. So what do we do there? So thinking about like, what does the practice look on your unit? And then again, providing training and support is so important. And this is an example, and again, I'll share my slides so you can look at it and read over it a little bit more. But it just gives you an example of this particular team that did shared decision making and sort of those very small steps that they took. And if I could say one thing on here on this last one, getting patient feedback is so important in your work, but also I think using those success stories. You know, we've had some really great success stories around treatment of severe hypertension and the outcome of the patient, as well as hemorrhage. Some of our teams saying, like, if we had not done this work, then we would not have been able to have a good outcome for this patient. And just remember, you know, change implementation is complex. You know, it is a series of cycles. Again, holding the gain means that you have to watch this cycle. We had a very large hospital system when they came into the NSDPQC said, we've been doing QBL for a long time. I'm like, okay, well, let's see, you know, go ahead and pull your data. And it was terrible. It was like 12% compliance. It was a very large health system. So they're like, never mind. We thought we had, but we didn't monitor it. And I guess we fell off. I call it going back down the cow trail, because I like that trail sometimes when I'm busy, my census is high and I have a lot of patients. And then just really recognizing that social aspect of change, like really understanding the how and why is going to be important for your teams, because there is that social aspect of change, including like physical implement, you know, like physically, how's it changing my environment? Why is it necessary? Like, why do I have to do it? And there's that emotional aspect, which is really part of sort of that culture on our unit and how well we are valuing QI and moving towards QI. I'm sorry, I'm rushing. I am rushing, Morgan, I promise. And there is the Cotter's model of change, and I won't read over that, but I think what's important with Cotter's and thinking about all of these things that are important when you are implementing change is that, you know, there is going to be a non-commitment. We have teams that are doing hypertension, have been working on it since 2018. We have a couple of large hospital systems I'm thinking of right now, and they finally are sort of like saying, we're not getting this, like we're not getting it, the nurses, the physicians. So now we're doing, you know, another QI team, or we're doing like a Lean Six Sigma, we're getting a new physician champion. So what is that response to non-commitment? And that can happen, right? You know, how are you modifying change? Is there incentive? Is there logical consequences to not conforming to the policy? You know, how is this implementation part of the job performance, or part of how we treat patients, you know, in our facility? Again, commitment to sustaining the change is really important. It has to become part of day-to-day operations. It has to be measured. There has to be training that is continuous. You can't do it one time. One of the big struggles with a lot of our teams right now related to change and implementation and sustaining change is new staff. There's so many new staff members, so many travelers, so many SNAP nurses, you know, all of those different people that are coming into their, you know, their units. So incorporating that into your system, and don't skip testing. Like, you've got to test first. You can't go straight to implementation. Shake out those failures first, get the naysayers, shake it out, and then move forward and adapt and adopt. And again, as you do small tests of change, you should have, you know, little failure as to just trying to implement some big change. And then really looking at your data and your stratification. And I switched to the next slide quickly because stratification is something that we do. It is important to our work as we work on equity work. We make equity part of everything that we do. It is a very large piece of our designation, our birth ready designation. It is a large piece of our breastfeeding breastfeeding designation as well. We bake it into everything we do, every conference that we have. We teach our teams how to confront their own issues, how to teach about implicit bias, equity, and racism. We are creative with teams that maybe have to start very small. Like, what is the first step that you can do? For some of them, it's just like asking the patient their race and ethnicity, you know, doing that self-identified. Maybe they hadn't done it. We had one hospital, we pulled their SMM data, and literally it was all Hispanic, and their Hispanic population is very small. So they were just clicking a box, and it took them 2 years to discover it was them. And so then they really, that's where they had to start, right? Double down, you know, not retreating or being scared, and really thinking about, for hospital teams, there's always something you can be doing. We always have an idea, we have a list. And so we're always really good at trying to help our teams move forward with their equity work and stratifying their data and really looking for gaps. And finally, make sure that you are also ready for spread, really knowing that the work doesn't stop with your unit. I think for many of us, you know, AIM is working on a new emergency room bundle, and that's going to help spread the hypertension work to the emergency room. For us, that's a biggie. We know that a lot of our patients in Louisiana come back to freestanding emergency rooms that don't have delivery services, and that's where they end up getting in a bind and having a poor outcome. So if you're moving to the emergency room, the PACU is another biggie for many of our teams, or the OR. You know, how are you, you know, getting ready for spread? And again, you know, who are you spreading to? What is the communication? How will you measure change? And sometimes there's overcoming a lot of barriers as you come into those other units that are maybe not related to women's services and children's services, but how are you, getting that work plan together and moving into spreading that change that you've done? Yes, I went fast. Sorry, Morgan, I did go over my 15 minutes.
Oh my gosh, you are totally fine. That was amazing. So thank you so much.
Yeah.
Questions we'll hold for you when we get into our breakout session.
Okay, that sounds good. I'm gonna stop sharing.
You are amazing. Thank you so much for being
here.
I
appreciate being here. Thank you.
Okay, so we are moving into our breakout session. I have practiced this. I have watched videos. This is our first time doing it live with this big of a group. So bear with me if we have a few technical issues right at the beginning. But first, you met 3 of our breakout room leaders. Our 4th one is going to be ran by our own Dr. Anna Tobias. She graduated from UND School of Medicine in 2010 and completed her OBGYN residency training in Grand Rapids, Michigan, and maternal fetal medicine fellowship at the University of Tennessee in Memphis. She's been practicing as an MFM at Sanford Health Bismarck since 2017. And she will be presenting some case studies, reviewing best practices. So that will be her breakout room. Everybody else will kind of be more question answer. We've given them some questions to kind of ask you guys if you're quiet at the beginning. So don't be afraid to come off mic, put your camera on. I'm going to start a timer on my end for 10 minutes, and then I'm going to be rotating the speakers out of the room. So your group will stay the same. You'll just get a new speaker and a new 10 minutes will start, and we'll make sure you guys get to hear from each of our breakout room leads. So I am going to send you all there.